So welcome everyone. Thank you for joining us this afternoon. My name is Paula Pinto. I am Program Manager for Policy and Engagement at All Ireland Institute of Hospice and Palliative Care. Palliative Care Week is finally upon us, and throughout this week we want to encourage people to talk about palliative care and its different facets. This public awareness campaign is aimed at the general public and professionals who work in the sector, and this is why Barbara Wren and All Ireland Institute of Hospice and Palliative Care partnered to host today's webinar, Creating Space, Clarity, and Containment to Manage the Emotional Impact of Working in Palliative Care. Today's speaker, Barbara Wren, is a chartered psychologist, and her company, Wren Psychology Associates, develops and delivers psychological interventions for healthcare organizations and their staff in the UK and Ireland. She has a keen interest in using narrative to develop individual, role, and system resilience as described in her book, True Tales of Organizational Life, which explores the containment that needs to be available to enable healthcare staff to manage the impact of their work while staying effective in role. She further deepened this work while developing a variety of interventions for a range of NHS organizations to support healthcare staff and systems to manage the impact of the COVID pandemic. She has worked with palliative care staff for 20 years, providing individual and group psychological interventions, and has described this work in a chapter titled Creating Space, Clarity, and Containment to Sustain Staff in Palliative Care, in the forthcoming Handbook of Palliative Care to be published in 2022 by Wiley Press. At the end of Barbara's presentation, we will open the floor for a Q&A session. Feel free to add your questions as the presentation progresses in the Q&A function. We will be recording today's session, and we will also be sharing the slides with you next week. We hope you enjoyed today's webinar. Barbara?
Thank you, Paula. Thank you very much for the introduction, and thank you to the All Ireland Institute of Hospice and Palliative Care for inviting me to do this webinar today. It's a real pleasure to be here, and it's great to see so many people who have signed up, and also just to see how much, we've just been talking before the webinar started, how much conversation you're creating, which I'm sure is what you've hoped, and how much interest there is in this week and this really important topic. What I'm going to do in the webinar is I'm going to draw on my experience over the last 25 years providing psychology to palliative care, and I kind of want to walk you through what I think is helpful for us to be thinking about in terms of the support needs of palliative care professionals. And I'm going to be drawing on my experience in palliative care, but actually also in other settings, and also linking to some models and frameworks that I think will be useful. And I've got a reference list that I'll come to towards the end of the presentation, just to kind of flag up some important bits of writing. In a minute, I'm going to walk you through the main topics, but I just wanted to start with this photo that I've got on the front page that you should be able to see. So this is a picture from, this is the Barrow River in Carlow. It's just beside a town that my mum and her brothers and sisters are from, in Bagnallstown, and it's, I want to draw your attention to it in two ways, just thinking about two things. So invite you really to sit back and think of these questions. One is about where you came from and why you're doing the work that you do, because I can see from the list that there are lots of different palliative care professionals. So, where did you start from? Where did your family start from, and what loss experiences have you had in your life? What's drawn you to this area of work, or what's drawn you to this webinar? Because I think it's very helpful to really think about the emotional impact in that context, which is what's the motivation to do the work, and how that motivation may change over time and in different contexts. And the other thing about the photo is, you can see, I managed to get this is taken in the winter time, just at the time that there's about half of it is above the water and half of it is below the water. And that's to invite you to think about what's below the surface really in this work, and also what's invisible in this work. Because I think when we're thinking about how to manage the emotional impact of any specialty area, it's useful to think about the emotional content of the work and many of the invisible aspects of it, almost like the water that we swim in. We can't really see it until we stop and we think about it, because we're so busy. And palliative care work involves attending to visible and invisible aspects of experience, and making decisions about when to surface an issue, when to put it into language, when to discuss it. So that idea of where you're located right now, but where you've come from and what's brought you to the work, and what's visible and invisible in the work, are kind of two kind of holding ideas that I just wanted to kind of start with before going into the presentation. So just to help you with a little bit more location, just a bit about me, so you get an idea of where I'm coming from with this webinar really, and the ideas that I'm going to share in the webinar. So I've worked in palliative care settings probably for about 25 years, and I started when I had a role in the Royal Free Hospital in London, where I was the in-house psychologist for the staff. And quite early on in that work, I was asked if I could provide some support to the palliative care team. There were a few different things happening at the time. There were some changes within the team, and I did some team development work. I worked with some individuals in the team, and then I developed a team reflection format, which was that the team would come together once every 6 weeks and have an hour and a half with me as a facilitator to really reflect on their experience over the last six weeks. And it was that they already had supervision. They also already had case discussion. The idea of this was that there was a team experience and there was a team absorbing the work. And that group is still running. I still facilitate that group probably about 16 or 17 years later, and have worked in other settings as well, in hospice settings and in hospital settings. And I've done some work with Marie Curie, both as an organisation, but also working with medical leads. The work that I do is systemic. I'm very interested in the link between the person, the role, and the system, and you'll see that in the presentation. And that model helps to look at staff experience, so that any one experience that a staff member is having or wants to think about can be thought about the level of them as a person, them in role, them in the system in which they're working. And I'm also very interested in using story as a way in to explore and understand experience, and also thinking about the difference between told and untold stories, and the value of telling stories and having them witnessed. And I've worked at all of those levels in organisations. And as I say, worked in the Royal Free, developing a model of in-house psychology to hospital settings. This is 20 years ago. There weren't that many psychologists. There were a few. We developed a network of psychologists working in hospitals, NHS trusts. There are a lot more services like that now. I also have done, I do a strand of work, which is consultancy when things have gone really badly wrong. And I've done that work, I do that work in both UK and Ireland. And I'm just mentioning that because I think it's both ends of the work feed each other. So developing intervention to support staff, but also going in afterwards to thinking, well, what happened here? And that really has informed my thinking about the things that can go wrong, and also the importance of preventing them. Obviously for patients, but also for staff. And I've been very involved in the last 2.5 years, like probably a lot of people on this webinar, in COVID and developing interventions in the context of COVID. So I just wanted to kind of give you a flavour of where I'm coming from, but also how those different areas of work feed off each other. And I'm going to just, the next slide just gives you an overview of the areas that I'm going to cover. First of all, I want to talk a little bit about context, the kind of unique context of palliative care. And you'll see that what I'm going to do is hold up a lens, and the lens is psychology. You know, this is the work. What is the psychology of the work? I want to talk a bit about the emotional complexity of the work. I think in very busy work areas, like all of you that work in palliative care do, there isn't, you know, you move from patient to patient, you move from situation to situation. Sometimes having the layers and the complexity just unpacked can be helpful to see how much you carry, how much you do. And then go into thinking about the 3 areas really for intervention to manage the emotional impact. Individual well-being, what the options are there, but very importantly, work design. One of the points really that I want to make in this webinar is that the challenges and the emotional impact of working in palliative care, they are predictable. On the work that I've done and that I've mentioned where things have gone wrong, it's as if we couldn't have predicted. And we do have a little bit of a bias to think in terms of the individual and individual well-being. People are stressed. What can we put in place to prevent them being stressed? Work design is a really important dimension here to mitigate predictable harm, predictable emotional burden of work. And then the third area is really thinking about the system in which the work is taking place and how that is creating opportunities, but also challenges for people who are doing palliative care work. I'm going to finish by trying to pull all of this together and think about maybe there's some similarities between what palliative care patients need and what the health professionals need. Maybe there's some similarities there, and then talk about some interventions. So let me just go on to think about the context. The area of work has some paradoxes in it, and I think it's worth kind of thinking about them. And also, I was thinking when I was putting the presentation together, and then when I was running through this morning, I was thinking about, well, how much of this, like you always do just before you're about to do a webinar, and you always think, well, how much of this is really obvious anyway? And it made me think about a lot of the work that I do now is running reflective space, either for individuals or groups. And really the value that I hope this webinar might offer of giving you a chance to press pause and really kind of think about these areas without having the responsibility to provide care or think about anybody else. So the first context is that you're working with people where things are happening to them that they don't want to happen. So supporting people when there are changes happening in their bodies, in their families, in their roles, in their relationship to the future. And coming back to the idea of the water, that we're swimming in, these changes require people to face really what are our most primitive fears, which are the fear of being abandoned and the fear of annihilation, the fear of not existing anymore. Really, really profound feelings stirred up in this context. The third level of context is that it's palliation, not cure. And the next level of context is that there are real opportunities because of the power of these contexts. There are real opportunities for very profound emotional experiences. There are opportunities for intimacy, for expressions of tenderness and love and creativity. Health professionals, we might be used to using that word love, but it's drawing on that part of ourselves. And it's also drawing on another part of ourselves, which is having to encounter our own vulnerability and helplessness and impotence. And these are very, very powerful experiences happening in professional roles. And I think to navigate them requires a level of insight, also agility, the ability to move between different parts of ourselves, between different emotional states, being able to manage anxiety, and being clear about positioning, where am I in relation to this patient? What is the task? What am I required to do while all these strong feelings are swirling around me, but also maybe inside me because of what's been evoked by the work. So that's the psychological context. And I'm just going to go on and unpack it a little bit in terms of this whole idea of emotional complexity and really kind of walking through the emotional complexity in palliative care work. First of all, there's a need for sensitive communication that's very, very mindful of people's beliefs, wishes, knowledge, ability to understand. Also, that's not just patients and families, but also professionals. Then there is the complexity of working with paradox, really. So keeping two opposing contexts in view. So on the one hand, helping people to achieve the best quality of life, maintain their well-being, balance reality with hope, while knowing, as the palliative care professional, the possibility of quick deterioration depending on the illness and the possibility of death. So keeping both in mind at the same time. Then managing anxiety, so managing uncertainty and managing risk, including clinical risk, while providing containment. So while being able to give patients and their families a sense that they are safe, that they are going to be okay, holding on to the unknowns, the risks, your own anxiety, while conveying containment. And of course, that's a very complex thing to do. And, thinking about, just bringing this to life with examples of maybe people I've worked with, sometimes when people find that difficult, what they will do, they'll provide certainty, not containment. And then that starts to make communication difficult, or managing patients' expectations difficult. It's a clinically complex area, so you're doing clinically complex work, depending on whatever role you have, while supporting painful changes in people's role and identity. It involves withstanding very powerful feelings, and I've described some of them already, but also feelings like anxiety and aggression and sorrow, without being derailed, without losing sight of what your task is in this moment, in this consultation, at this stage of an illness. It involves bearing witness to suffering and making decisions about what level to address it and alleviate it: physical, emotional, spiritual, social. It involves coming to terms with one's own sense of vulnerability and making sense of one's own relationship to feelings of helplessness and impotence and fears of failure. Because it's a lot of people are drawn to healthcare work because they want you to rescue. Palliative care, to work in palliative care, you've got to be able to manage that instinct wisely, and over time be able to really develop a helpful relationship to feelings of impotence and fear of failure. And also manage other feelings, maybe less pleasant to talk about, maybe less easy to talk about. And the reason I'm putting this example in is because part of the spaces that I've been involved in facilitating, including large organization spaces like Schwartz rounds, small groups, individual work, and in those spaces, I think it's very important to allow people to say the unsayable. And this is one area of unsayable. Maybe people's feelings of fear about bodily deterioration or feelings of disgust. Being able to manage one's own feelings in a way that patients are able to cope with feelings of shame or fear of being abandoned because of the ways in which their bodies are changing. The other strong feelings and I've alluded to them as well, is being able to manage one's own desires for intimacy and attachment, and being able to express tenderness, and a sense of longing that can be evoked by the patient's need for us, and being able to understand those feelings and be aware of them, but not necessarily act on them. To be able to become close enough to patients, but not enmeshed. Be able to pull far enough away to be objective and do clinical reasoning. Really subtle parts of the emotional complexity, and manage one's own relationship to one's own experience of loss, which may have brought people to work in palliative care in the first place. There's some really interesting psychological work looking at why we choose the careers that we do, why we choose the specialties that we do, this idea that part of the unconscious reasons why we choose these areas is to repair something, to repair an experience that we've had. And if that's the case in terms of a loss experience, palliative care provides ample opportunities for that. I've been thinking lately in the last couple of years about how this relationship changes over time, probably because I'm getting older. And I was thinking about a nurse that I worked with in one of the groups that I've run for a very long time, whose mother died when she was very young. She was only, I think, about 7. And she became a palliative care nurse, a really brilliant palliative care nurse. And then found that when she had her own children, quite recently, her children are under 5, that the work started to feel a lot more burdensome to her. I thought that was so interesting. I wondered whether it had fulfilled its need. And now as her life was changing, her relationship to the work maybe was changing. The other complexity is working with complex systems and having to move across systems, so health, social care, community, hospitals, all of those things. Working creatively to respond to differences in culture and spiritual beliefs, preferences and needs. And then attending to the uniqueness of each individual, despite knowing the typical illness trajectory. So you see a patient for the first time with a very sad or serious diagnosis. You've seen it 100 times. It's their first day. In some of the rounds work and the storytelling work I've done, I've been involved in working with health professionals just to talk about how do you manage to do that? How do you manage to stay with the person where they're at, but you know what the trajectory is going to be. So that's mapping the territory then of the emotional complexity of the work. And given that, how should we start to think about managing the emotional impact of the work? This is the territory, this is the water you swim in if you're working in palliative care. There's 3 areas, as I said, to look at, and the first of them is individual well-being. And that can involve offering reflective space, offering one-to-one space. I think it's invaluable to have space to process the impact of work, to have space to understand oneself, to have space to decompress. And I think that, talking about the emotional challenges of palliative care, but actually there are huge opportunities as well to develop oneself, to develop one's understanding of oneself, to develop your own capacity, really, to bear difficulty. The kind of, in terms of thinking about individual well-being and thinking about what are the kind of aspects of individuals to look at, what I've done here is I've got a list of things that will affect the way in which we relate to our experience. So one is our cognitive style. That means the sense we make of what happens to us. We know that cognitive style predicts our mood. We know that there are particular patterns of ways of thinking that can predict low mood and vulnerability to depression. And we know that cognitive style can be developed, expanded, changed through therapeutic interventions like CBT. One of the questions that was asked that one of you asked was about ACT interventions for palliative care. So that's a form of therapy called acceptance and commitment therapy. And somebody asked about what I thought about their effectiveness in palliative care staff. I don't know that much about the evidence. I do know a bit about this work. And actually, if you want to have a look, a colleague of mine, Paul Flaxman, if you Google Paul Flaxman, has done a lot of work on acceptance and commitment therapy in relation to recovery from work. But it's a very good model in relation to the development of psychological flexibility. It's a model that's very much related to connecting to your experience in the moment, being able to sit with the experience and kind of increasing your capacity to stay connected to yourself at times of difficulty. So really a really good model to think about, and works on the idea of psychological flexibility. Another area to look at in terms of individual well-being, and this is something that I do a lot in the individual work I do, is thinking about work as not as a static thing, but as a relationship. In fact, it's quite a big relationship in our life. It takes a lot of our time. How do we relate to it? Do we relate to it? What are we investing in it? What motivated us to do it? What do we need from it? It's a good question always to ask. What do I need from work? What is work giving me? Sometimes I've been thinking about with some groups and individuals where work it's almost a form of emotional regulation. And I think that's very useful to kind of pay attention to, how an over-investment in work can be about an anxiety about not being able to manage some of the feelings that get processed in work. And again, you can see what I'm doing in my mind is I'm just linking to where people get unstuck, where people get into trouble. Sense of coherence, again, is a really important area to think about in terms of well-being, and it's very relevant to interventions, as I say, like a large group reflection and like supervision and like consultation, because what they aim to do is to give a sense of coherence. And for those of you, lots of you I can imagine, who work really busy jobs in hospitals and other settings and know you're very busy and get home and think, I've done a lot today, but I don't seem to have got very far down on my to-do list, and I couldn't describe it to you unless I have a lot of space. And then you maybe have a good appraisal, or you have a really good supervision session. And what that is giving you is the sense of coherence. And that's what story gives as well. It gives a shape to experience. And the psychologist called Antonovsky has done a lot of work on this, looking at the development of resources. So this is kind of slightly different to the development of skills to manage stress, the development of resources. Self-compassion, also really important in terms of individual well-being. How do we talk to ourselves when we're struggling? Are we punitive? Are we self-critical? Are we, do we have self-compassion and understanding? Are we curious? For those of you who, I'm sure lots of you are really familiar with this work, but for those of you who aren't familiar, the psychologist to start with is Paul Gilbert, who's written a lot of work in this area and done a lot of really important interventions. Other skills, relationship building skills and emotional intelligence and problem solving skills, all really important to well-being, all can be developed through programs, through reflective space, through supervision. And, you know, when I described the work that I do with the Royal Free Palliative Care team, that what they have then is every 6 weeks, this sense of coherence. We have the same structure, same beginning and same end to each session. So this idea that even when you're out busy, having a very, very busy day, there is somewhere that's part of the culture of your team that you can return to and bring those confusing experiences. And the idea is that over time, hopefully that will bed down and embed a sense of coherence. So that's individual well-being. And I wanted to move now to work design. And as I said already, I think this is such an important area and we don't pay attention to it enough. And this is where we can mitigate some of the harm. And this is where we can think about how to protect people. But I am also mindful of one of the questions about that was again that somebody said when you logged on, really valuable question. And I can imagine there's lots of you have this question. You might even be having this question as you're listening to me, maybe thinking, well, chance would be a fine thing, but where I work, and that was the question about you know, short staffing. And maybe we can bring that into the discussion because that definitely is an issue. But thinking about work design, we know an awful lot about how to design work to protect staff. We know the kind of jobs that will predict job strain, and we know the kind of jobs that will predict challenge and good learning environments. And one of the good models to look at is the demands control support model. So this model outlines the 6 domains of work and what are the relative balance of each of those domains to have to keep us healthy. And for those of you, again, lots of you who might be familiar with this, one name to search for is Karasek, where the model is being looked at in terms of predicting both depression and heart disease. The other thing to look at is look at the UK HSE website, which describes how this model has been used to do stress risk assessments. But just to give you a quick overview, we know that jobs that are better for our health are jobs where there's a good balance between demands, control and support, where roles are very well defined, relationships are positive and change is well managed. And jobs that are high in demand but low in control and low support predict job strain. And in lots of jobs in healthcare now, particularly after the 2.5 years that we've all lived through, it's not that easy to reduce the level of demand. So the things to think about there are people's levels of control and the support available to them. The other aspect of work design that's important is the role, the relationship between the role and the task. What is the task of the role and what is the task of the team? When I go in and work with teams, that's often one of the first exercises. You know, what are you here for? What is the task of the team? Does everybody agree? Does everybody see it in the same way? And how is the team positioned to get the work done? We know that good teamwork is protective of the well-being of staff. It's also a very significant influence on patient safety. And Michael West has done a lot of work in the NHS on teamwork. We also know that management style predicts emotional exhaustion in staff and that containing management protects staff. And again, if you're interested in looking at that, a good place, one good place to look, again, it's UK, but it's the Chartered Institute of Personal Development, where they've got a lot of the evidence on management style, the impact of management style on staff wellbeing. I know I'm covering a lot, but I'm just mapping the landscape. I hope it's not too much. It's funny talking and not seeing your faces, so I don't know how it's landing, and I hope it's not too much. I just wanted to move into the third lens, really, which is to, if you imagine the first lens is kind of almost looking into yourself, into the person. The second is looking at the design of the work. And this lens is almost going right above and looking down, looking at the system and how it works, because all of those things will impact on the well-being of staff and staff experiences and on the emotional impact of the work. It's easier to manage the invisible aspects of the work when the work is well designed, when there's containing management, and when the system is coherent. So the things to look at there are interfaces and interdependencies and positioning, and also how does the organization, depending on whether the organization is a hospice, obviously that's different to a hospital, but what is the organization's relationship to the work of palliative care and the reality of death and dying? If it's a hospital context, for example, with the palliative care team, is the palliative care team integrated or is it split off? So palliative care is where doctors send patients when they can no longer save them, because that happens, and that creates all sorts of complexity for palliative care professionals and teams. And lots of you, I'm sure, have been involved in work in hospitals where there's a lot of work to move upstream and get into specialty areas and work with them to integrate palliative care and palliative care thinking as early as possible. So there's the three domains. And when I was thinking about how to try and pull this together, I was thinking about how, if you were to try and simplify, and think, well, what do staff need? What do staff need to manage the emotional impact of the work? And I think about this in other areas as well as palliative care, that a lot of what staff need is what patients need, a sense of control, some clarity, a sense of being held, and also a sense of meaning, and an opportunity to kind of return regularly to the meaningfulness of the work. And so I wanted to just share with you that idea of what nourishes us is what allows us to sustain ourselves, and ensuring that people have access to the meaningfulness and have a chance to kind of stay connected to the meaningfulness is protective. So this idea of authenticity and meaning is vital for patients, but maybe vital for staff as well. So this is a quote from a book by Paul Kalanithi, and I can imagine lots of you are familiar with this book. I put it on the reading list. It's a really powerful read about a doctor who was diagnosed with terminal cancer, and it's called When Breath Becomes Air, and it's really, really, really beautifully written book. And this is a quote from when he's having his first appointment after he knows that he's very seriously ill, and he's meeting with his consultant, who I think is a colleague, and he's planning to play it as a doctor, get the facts, get the data, get busy thinking. But she doesn't allow that to happen, and she treats him as a patient. And I think this is such a great sentence. He says, it occurred to me that my relationship to statistics changed as soon as I became one. What patients need is not scientific knowledge, but existential authenticity. My doctor hadn't given me back my identity. She'd protected my ability to forge a new one. And finally, I knew I would have to. And I think there's a couple of things that I just wanted to pull out there. One is the idea of being authentic. And the other is that, when I read it, I thought, the doctor didn't confront him with the fact that she, how he was going to play it, how she was going to play it. She just went in at a different level. And I guess that's what a lot of you are doing all the time in your work. It's what you don't say, but how you relate to the person that helps them to make the shift. And I think that idea, to do that, you have to be able to be in touch with your authenticity and your vulnerability and use that actually as a strength in the consultation. And I think books like his and one or two others that I've mentioned are very powerful, because at some level what you're reading about is, this idea of one group of humans having an experience that the other group of humans are helping them with, but they will be eventually having that experience too. That's the reality. Whether we're in touch with it or not, whether we're staying in our professional role or not. And so that idea of allowing people to connect to the real impact of the experience and the meaning, I think, is very, very important. And that's why story is really useful. So putting it all together then, I think the way to manage the emotional impact of work is to design, to create the conditions for productive, satisfying work. So you see, I put design first, in as much as that's possible. Obviously, it's resource dependent and system dependent, to provide interventions to support individuals and teams to attend to the seen and the unseen aspects of their work and their motivations, and how they might change and how life events may change them. And thirdly, to relate wisely and very proactively to an organizational culture and context, and be aware that that will be impacting on individual level experience. I think the real psychological challenge of healthcare work is to stay in touch with meaning without being overwhelmed by it, while staying in role and on task. And that requires people to be able to understand and make sense of the emotional complexity, hold it, and sometimes we all need holding to be able to do that, and stay in role, and not veer off role, but stay in role, stay in the team, and stay on task. And I think psychological interventions offer the possibility of integration, because to stay in role, that sometimes means that we have to file away experiences or suppress feelings or suppress instincts to stay in role. And that's appropriate. But it can lead to an experience of disconnection, which can also be invisible. One of the things I've been very involved in over the last year has been doing a lot of group work. So this isn't in palliative care, a lot of group work in hospitals, providing space for people to process the impact of COVID, including chief executives and kind of very senior leaders across the board. And one of the things that's really obvious is the amount of unprocessed experience. Like, if you open the space for people, they're stunned really by what they filed away. And I think that's what I mean about the sense of disconnection. It's necessary, but over time it can create problems, and it can create things like burnout, numbness, a sense of disconnection from patients. Because really what we've got to do in this work is to be able to move from intimacy to objectivity and back again, over and over and over again in the day. Not stay in one place or the other, but keep moving between them. And it's when people become stuck in one or the other place that things can become problematic for individuals and teams. So interventions can allow people to have compassion for themselves, and separating the dancer from the dance is the idea of separating from the dynamics that are evoked around the work. So a sense of urgency, a sense of desperation, rescue me, collude with me, save me, all of those, being able to separate from those and make sense of them. Having space also to make sense of oneself and one's own inner world. So maybe what staff need, as I say, is what palliative care patients need: a sense of coherence, creativity. By that I mean making meaning, building relationships, having some control over an illness, and being able to develop and shift a relationship with support and contact, being in touch with others, not being abandoned, holding these experiences in relationship. So much more important now after COVID, well, not after COVID, at this stage of COVID, while we're all living in such disembodied ways. Here we are on a screen. In the book that I wrote, I described some of these ideas in a little bit more detail in relation to the work that I did on Schwartz rounds, and about the value of creating safe links between private and public experience. So there's an opportunity to really talk about the fact that even the feelings that might feel very difficult are usually not unique. The strong feelings that are evoked by palliative care work are not unique, and it's such a value to be able to talk about them. Creating a sense of resonance creates a sense of community, and also telling stories creates permission. And the more permission we have for all the experiences we have, the greater our own resources to withstand our own emotional experiences in our work. I've mentioned some references, and these are books that I found really, really powerful and really useful. Rachel Clark is a palliative care consultant lots of you will be familiar with, and she wrote this book about her work, but then also about her father's death just a couple of years ago, and her experience of that as a palliative care consultant. Atal Gawande's book, Being Mortal, Medicine and What Matters in the End, is a kind of call to resist urgency. Think about the whole context of meaning and what patience means, and really kind of what he's talking about is the risks of over-intervention and the importance of stopping and thinking, the importance of accepting death and dying. Paul Kalinathi's book I've mentioned already. Catherine Mannix is another UK palliative care consultant whose book, With the End in Mind, is a very powerful read. And she's just last year written another book, Listen. It's the rest of the title is The Art of Tender Conversation. Corrie Taylor was a New York journalist who wrote a memoir about her experience of dying, which is really, really powerful and beautifully written. And I put the two references to the book, and also this chapter that's coming out in the Wiley Handbook of Palliative Care. It's next, I got the date wrong, Paula, it's next year, and it's 2023. I thought it was this year. I just want to thank you very much for listening. I think this picture is to capture kind of the agony and the ecstasy, the challenge of the work, but also the meaningfulness of the work. And I hope I've made kind of the point that I wanted to make is about being able to move between both, and that we need to design work in a way that allows people to do that and create space to release what has to be unspoken to make that movement possible in professional roles. Thank you very much.